Firstly, the tissue is fixed, stuck into an embedding medium, and then it is cut into very thin slices and put onto a glass slide. After that, it is stained, and then a cover slip is put onto the microscope slide, and then you can image the sample. Now, one of the problems with this is that it kills the tissue. It also takes a lot of time and can introduce artifacts into the tissue sample. Also, only a small percentage of tissue is generally processed, so observations from histology are still subject to sampling error. A recent development in microscopy is confocal microscopy. With confocal microscopy, you can image thick specimens with minimal preparation. Benchtop confocal microscopes are highly configurable and usually have a number of different laser wavelengths available and multiple detection channels. They generally fit to conventional optical microscopes, but they are very large, heavy pieces of equipment, usually set up on an optic bench to keep everything in rigid alignment, so they are not portable. Confocal microscopes can be used to image living intact tissue, but they are usually integrated with conventional microscopes, which also limits what you can image with them. Animals need to be immobilized, and this to minimize movement of the animal. And this also means that you have very few areas on the animal that you can image effectively. So endomicroscopes, on the other hand, are a small handheld confocal microscope that can be touched against tissues of interest. They can enable capture of real-time histology equivalent images, including from large animals and humans. In this example, we are imaging inside the uterus of a live horse with an endomicroscope incorporated into a flexible endoscope. This sort of imaging would not be possible using a benchtop microscope. So how does a confocal microscope work? Traditional confocal microscopes have an illumination source, usually a laser, that sits in front of an illumination pinhole. Light that goes through that pinhole is then focused through optics into a sample where it excites a fluorescent return. The fluorescent return follows the same path back through the optics and is split with a dichroic mirror. The light that goes through the mirror then goes through another pinhole that has the same focus as the illumination pinhole, and this confocal pinhole is in front of our detector. What this means is that the detector only sees light from the focal point of the system. Now, with scanning technology, you can move that spot back and forwards in the focal plane and generate an image by looking at variations in intensity at your detector. You can also change the focal plane up and down, so you can generate three-dimensional images. Now, with our endomicroscope, there was an Australian inventor in the 1980s who worked out that you could use the tip of an optical fibre as both the illumination and confocal pinhole in an endomicroscope. So the way our endomicroscope works is we shine laser into an optical fibre. That goes through into our scanning unit. Now, the light that comes from the tip of our optical fibre projects through our lenses and is focused into our tissue sample where it excites fluorescence. This fluorescence goes back along the same beam path and is focused into the tip of our optical fibre, goes back through to our processor where it is split off to a detector. we have inside the scanner at the tip of our endomicroscope a scanner that moves the tip of the fibre in X and Y, and we can change the focus of our light into the sample by changing the focus between these two lenses. Okay. Images captured by endomicroscopes are an on-face or surgical view of the tissue, not the traditional cross-section seen in pathology. Now, in this slide here, you can see what a traditional cross-section looks like from a section of gut. You can see the way the crypts go down into the sample. But if we're using an endomicroscope, we're going to be looking at something that looks like this, where we look across the face of the tissue. This is an on-face typical histology view, and this is the equivalent confocal endomicroscope view of the same tissue. Now, what you can see in the confocal endomicroscope view is that it matches very well with the histology on-face view, and you can see cellular detail in the confocal endomicroscope image. The magnification of our microscope is around about 1,000 times, and that comes from a field of view of just about 0.5 millimetre in X and Y. We also have sub-micron resolution in X and Y, and an axial resolution or slice thickness of around about 5 microns. We can move this optical slice up and down in the tissue. That gives us a 3D focusing capability, and you can see in the images on the slide the sort of difference you get when you change the imaging depth. So we can image both surface and subsurface features with the device. Okay, there are many advantages to imaging living tissue rather than looking at a thinly sliced piece of dead tissue. We can image it in its natural state. We can see how the specimen works in real time. We can look at interactions that happen in the living tissue, and we can also observe disease progression over time and monitor the response to therapy. So in summary, a confocal image is formed when a laser is focused into a point in a sample and it excites fluorescence. A detector measures the intensity of the fluorescent light at that point, and the point is scanned through the specimen. So our image is an array of point intensity measurements, and it measures the fluorescent dye distribution in the tissue. So it's not like a photo. I'll now play a video showing you the components of the 5-2 endomicroscopy system. So we have a processor here, which has a laser and a detector in it. We have a computer and a monitor as well. We also have a foot switch where we can control the depth of our imaging and also collect images. And we have an array of different probes from long through to short, including a probe that has a sterilizable sheath that we can put over it. The short probes can also be put into a high precision manipulator stage for small animal imaging. And all probes can be handheld. For instance, I'm touching the probe up against the pink cloth on my finger, and you can see the images showing up on screen. Okay, the specifications of our microscope are a little bit different to what you would see with a conventional confocal. Because of the miniaturization of the system, there are fewer features and simpler operation than a benchtop confocal. We only have a single illumination wavelength, in this case 488 nanometer blue laser. We only have one objective lens, which is built in to the tip of our scanner. The laser power is also limited to 1 milliwatt, and that's to prevent users from having their eyes damaged by having a laser aperture that you can wave around in the room. The image only has one detector, which means the standard image format is grayscale, like ultrasound, MRI, or X-ray. So what can we image with an endomicroscope? With confocal microscopes, you can really only image close to the surface of the tissue. This technology is suitable for imaging of epithelial tissue, particularly mucosal epithelial tissue, where topical application of dye enables good images to be captured easily, including in the oral cavity, the nasal cavity, and the airways, the gastrointestinal tract, reproductive tract, and the skin and eye. It's also possible to use endomicroscopes during open or minimal invasive surgery in humans or animals. This enables imaging in the thoracic and abdominal cavities, and also the walls of internal organs such as the gut, the liver, and the kidneys. The surface of the brain, surgical wounds, and tissue removed during surgery can also be imaged to enable rapid analysis of the tissue. There are many applications of endomicroscopy, including imaging cancer, tissue regeneration, cell death, cell tracking, drug distribution, and molecular imaging. The example I will discuss today is the use of endomicroscopy in oral cancer research. Globally, there are nearly 500,000 new oral cancers diagnosed per year. Many of these cancers develop from lesions in the mouth. These lesions are seen in about 5% of the population, and around 3 to 5% of those lesions will become cancer. If the cancer is identified early and treated, the prognosis is good. If the cancer is found after it has metastasized, the prognosis is much poorer and the cost of treatment is a lot higher. Therefore, being able to image lesions in vivo and to determine when they are becoming cancerous is highly desirable. Here we have a picture of an oral lesion. This one is called a lichen planus, and you can see it here on the screen. This is a common inflammatory condition in the mouth, and it can frequently become cancerous. This lichen planus has a positive margin for squamous cell carcinoma. But the question is, where is it cancerous? Where is it dysplastic? And where should the surgeon cut? When a surgeon removes an oral tumour, they try to leave a cancer-free margin to reduce the risk of subsequent recurrence of the cancer. The size of that surgical margin can be between 5 and 20 millimetres, and typically it's around 7 to 10 millimetres. However, tissue removed during surgery can lead to additional mortality and morbidity and significant irreversible impairment of chewing, talking, swallowing, and tasting. So reducing the amount of tissue that has to be cut out without increasing the risk of recurrence of the cancer is highly desirable. So our objective is to determine if we can accurately identify the oral cancer margin and provide the patient with the best long-term outcome. These images were taken during a study in Perth, Australia, using the 5.2 to look at oral mucosa. The top right-hand image here shows tissue that has been stained with a dye called acroflavin and shows dysplasia. This image was taken from the margin of a tumour. We can also see cell crowding and an increase in the nuclear cytoplasmic ratio. In the bottom left here, the bottom right here, we also have an acroflavin stained sample, and this one is from the center of the tumour and shows cancer, crowding of cellular nuclei, cellular pleomorphism, and disorganization of the cells. And these are all features that can be seen on the comparative histology in the middle of the screen. Next, I'll play you a video showing you how easy it is to capture instant histology equivalent images inside the oral cavity. In this video, I'm applying a topical dye called acroflavin onto my oral mucosa and then touching the endomicroscope onto the tissue inside my mouth. I can change the imaging depth and the laser power to get a clear image, and touching the tissue with the tip of the probe provides X, Y, and Z stability between the tissue and the probe. This is an image sequence from my tongue showing sensory papillae and squamous epithelial cells. The dye used here again is topical acroflavin, and fortunately for me, all of the tissue that I've imaged in my mouth is normal. Another commonly used dye in endomicroscopy is fluorescein. It's a dye that's routinely used in retinal angiography, and it has been used to image deeper structures in the mouth than you can see with topical dye application, including blood vessels. Although this has not been used much in the oral cavity, it has been used extensively in endomicroscopic imaging of the upper and lower GI tract and in brain imaging during tumour resection. In Australia, we are finalising plans for 2 studies to see if we can use topical fluorescein to identify tumours in the mouth, and 1 study to see if IV fluorescein can be used in resection surgery to identify tumour margins. These images were taken in the mouth following topical application of fluorescein. The microscopic structures, cells and subcellular details can be seen, although the way the dye stains the mouth is quite different to the way acroflavin does. A recent study in India found that fluorescein labels cancer in the mouth better than healthy tissue. We've not tested this yet with the endomicroscope, but expect to be able to do so soon. Imaging after IV injection of fluorescein enables deeper structures of the mouth to be imaged. The top images on screen are of the floor of the mouth after IV injection of fluorescein, and you can see blood vessels, irregular cell patterns, and increased vascular permeability around the tumour site. Optiscan is planning to test if IV fluorescein can assist the mapping of tumour margins prior to surgery. Lots of people are working on developing fluorescent dyes that will bind to specific receptors or other molecular targets. An example of a molecular marker under development for identification of oral tumours is PARP-IFL. This dye is a modification of a chemotherapeutic drug called olaparib. It binds to the DNA repair enzyme PARP1, which is overexpressed in many types of tumour cell. In the endomicroscopy images, the binding of PARP-IFL to tumour cells can be visualised, and you can see that in the two images at the top, where we see images from a tumour marked with PARP-IFL and also from the tumour margin. Optiscan is working with researchers from Memorial Sloan Kettering Cancer Centre in New York, as well as researchers in Australia, to study the use of this marker in oral cancer. Endomicroscopy can also be used in animal models such as rats and mice for learning about the progression of cells from normal to cancer. The technology enables real-time capture of histologically equivalent images from multiple sites over an extended period in living animals. Endomicroscopy has been used to study a number of other things, including brain, gastrointestinal tract, reproductive organs, drug distribution, and tissue culture. This video shows a glioma in a rat brain, and you can see the blood flow around glioma tissue in the brain. And this slide shows a montage of endomicroscopy images from a brain tumour, and it shows the tumour itself, a margin where the infiltrating tumour cells are going into the normal brain, and also normal brain. This is a con vivo which Optiscan and Carl Zeiss have been jointly developing together for neurosurgical applications, specifically looking at brain tumour resections. Optiscan manufactures and supplies the endomicroscopy components to Zeiss, and the imaging technology inside the con vivo is the same as all of the other endomicroscopes that Optiscan manufactures. Endomicroscopy has been used to study the turnover of mucosal epithelial cells in the gut, and it is possible to see gap formation in the mucosal cell layer after apoptotic mucosal cells are ejected, and to watch as the gaps are filled. In this slide, you can see cells being ejected from the mucosal epithelial cells, the mucosal epithelial layer, and you can see the gaps that are left after those cells are ejected. In this slide, you can see the remains of a dead cell being ejected here, and you can see the change to the permeability of the mucosal layer where fluorescein from the bloodstream is being released into the lumen of the gut. In this study, gastric mucosal gaps have been looked at for the implication in shedding of mucosal cells being involved in inflammatory bowel disease conditions. What we see in inflammatory bowel disease is an increase in the turnover of these epithelial mucosal cells and large areas in the gut where you have no epithelium left because all of the cells have been shed. You can also see bacteria getting into the mucosal layer of the gut through these gaps. Endomicroscopy has been used to identify tumour margins in a number of tissues. In this study, it was used to identify tumour margins in rectal cancer surgery. In the top slide here, you can see a margin that is normal tissue. So this is a negative tumour margin. And in the bottom slides here, we can see a positive tumour margin. This is what cancerous tissue in the rectum looks like. A large trial conducted at Shandong University in Jinan, looking at the ability of the endomicroscope to detect gastric superficial cancerous lesions, was conducted. It was found to have a higher sensitivity, specificity and accuracy for identifying early gastric cancer than white light endoscopy alone. Another large multi-centre international clinical trial looking at Barrett's cancer had similar findings with improved diagnostic accuracy, and the technology enabled real-time decision-making during endomicroscopic procedures. A study in Melbourne found that endomicroscopy could rapidly identify abnormal tissue, including a characterization of the grade of cervical intraepithelial neoplasia. You can see in the slide we have normal, SIN1, SIN2 and SIN3. We have, as the dysplasia increases, we see increased crowding, irregular shaped nuclei and cells, and severely abnormal cells when we get to SIN3. Animal studies using the endomicroscope have been used to look at vaginal barrier function in sheep and how it changes after the application of spermicidal gel. A high percentage of mares have difficulty getting into foal, and this can be very costly for horse breeders, as stallions are very expensive to hire. In this study, endomicroscopy is being used to image the uterine endometrial tissue in mares to identify endometritis, which causes infertility. In this study, endomicroscopy was used to image the proliferation of blood vessels in the skin of hairless mice, and you can see normal skin here and melanoma affected skin here. In this study, endomicroscopy was used to image drug delivery into liver cells by nanoparticles containing drugs and fluorescent dye. The images show the binding of nanoparticles to the cell membranes and, over time, the delivery of the contents of the nanoparticles into those cells. The time course of this experiment was around 2 hours. So you can see you can get good stable images over an extended period of time in the same animal and study active processes. Another application of this technology is to image living cells in tissue cultures. In this slide, you can see cells in culture being imaged inside a biosafety cabinet here. When you're using a probe in this situation, you can either touch your tissue or you can have the tissue with a gap between the probe and the tissue, either filled with air or water. And this can enable you to image cells growing in a sterile environment, and you can image these cells over a period of days. So in summary, an endomicroscope is a handheld confocal microscope. It's flexible and simple to use and enables real-time imaging of living tissue and rapid virtual histology. One promising application of this technology is in imaging oral lesions, where it has been shown to be able to identify the difference between normal, dysplastic and cancerous tissue. This may evolve into clinical procedures for long-term monitoring of oral potentially dysplastic and cancerous lesions, as well as assisting surgeons in mapping the edges of epithelial cancers in the mouth prior to or during surgery. There are many other applications of this technology, including imaging other epithelial cancers, such as in the stomach, colon, and esophagus. Also, the reproductive tract, such as the cervix. It has been used to image membrane permeability changes, blood flow, drug binding, and a range of other imaging applications where real-time imaging of structures and processes that occur in living tissue can help to answer questions that could not previously be answered. I'd like to thank all the researchers and collaborators from around the world who have used our endomicroscopes, and thank you for your attention.